My job this morning is to provide a bit of background and history related to this conference, and specifically to describe the evolution of the life participation approach to aphasia and AphasiaAccess. For many of you, I know this is going to be a review, but I think it's important to set a context for the next couple of days and make sure we're all starting from the same base. So, first, I'll give you a little history. Then I'll talk about Living with Aphasia Framework for Outcome Measurement to help us situate our thinking about LPAA. And finally, I'll talk in more depth about the key values and concepts of the life participation approach to aphasia. So, to start with, I'd like to create a bit of context with a story about a patient that I had back in the 1980s. Sarah was a 61-year-old lady who managed an attorney's office. She had loads of friends, multiple interests. She was what I would really describe as a go-getter. Shortly after a big anniversary party that she had organized, Sarah had a stroke, resulting in significant non-fluent aphasia and right hemiparesis. She participated in inpatient and outpatient rehab and was then discharged to live at home with her husband. Her outpatient discharge report stated that her language recovery had stabilized, and she was described at that point as having moderate Broca's aphasia. Her communication was described as functional for managing at home. Her SLP described her as enthusiastic and motivated and anxious to get home to resume her life, a story that a lot of us have probably heard. I became involved with Sarah about a year after onset when I received a call from Sarah's husband, who felt that she really needed to come back into therapy. He described her as depressed and said she had pretty much stopped communicating. When I first saw her, her communication was actually consistent with what the discharge report said, moderate Broca's aphasia. She was pretty good at getting her point across, and socially she was delightful. She was really a lovely lady. I noted from her discharge report that she had worked on things like lexical retrieval, sentence formulation, writing, and some functional communication tasks. And all of that seemed perfectly appropriate to her impairment. However, it was clear from sitting with Sarah that she was bored, depressed, and very, very insecure. She said she couldn't talk, and so she really couldn't maintain her friendships. Her friends had really drifted away. Her prior activities, like managing an annual charity ball, playing bridge, and working at her job, she said were no longer appropriate for her. She said she had no reason to get up in the morning other than cleaning the house and doing laundry and that sort of thing, pretty grim. She didn't seem to have the skills or the confidence to re-engage in her former life activities or find new outlets for her life. Her focus was on what she could not do rather than on her strengths and potential. Her husband, an engineer, didn't understand aphasia. He didn't understand his role in her recovery, and he was impatient with Sarah's change in personality from a vibrant and outgoing woman to a withdrawn and anxious wreck. So what had happened in the 6 months after her discharge from aphasia therapy? Sarah was a perfect example of someone who significantly improved in language but remained socially isolated and depressed. In short, Sarah was not living well with aphasia. In fact, Sarah's situation is at the core of the life participation approach to aphasia. That is, addressing the need for language recovery, but also figuring out how to support life with residual aphasia. So this story is one reason that many of us became involved in LPAA and similar philosophies, the need for a broader conception of aphasia rehab. But recognition of this dilemma didn't start in the 1980s when I saw Sarah. The path to LPAA goes back much farther. Back in the 1950s, Martha Taylor Sarno was advocating for attention to how the person with aphasia lives life. She implored clinicians to consider functional aspects of communication. She also worried about psychosocial consequences. In fact, she wrote, "The literature reflects little research and sporadic, generally unsustained interest in the psychosocial sequela of aphasia. In clinical practice, this aspect of aphasia is often acknowledged, but not addressed or managed." So the journey towards a life participation model began years ago with Martha Taylor Sarno leading the way. And of course, others were front and center on this path. Audrey Holland talked about the fact that people with aphasia can, in fact, communicate, even if they can't talk. She stressed that there's more to communication than language and incorporated the growing literature on pragmatics into aphasiology. In her usual cut-to-the-chase manner, Audrey said in 1983, "Clinicians might try talking to patients occasionally instead of only working on their language problems." It's interesting how this comment way back in the 80s foreshadowed her contributions in the area of life coaching and counseling. The problem at the time that Martha and Audrey were urging clinicians to pay attention to the whole person was the prevailing healthcare model, the medical model. In this model, the healthcare provider is the expert who directs treatment in a relatively authoritarian manner, creating a power asymmetry in the relationship. In the medical model, the person with aphasia is the problem, so the aim is to fix the person. In the medical model, the explicit goal is recovery of language to restore language to normal or premorbid abilities. If language is not recovering, then the patient's discharged, that idea of the treatment plateau. Theoretically driven treatments that were emerging, such as pica therapy and psycholinguistic approaches, fit well into the prevailing medical model, where the need to recover from impairments was paramount. And clinicians were swept along in the desire to be part of the established medical community. But there were niggling worries about clients like aphasia, who we thought back in our minds should be better. They should be doing better than they were. As we entered the 1990s, aphasia services began to experience pressures from various directions. Diminished healthcare dollars meant that we could no longer offer long-term treatment for aphasia. Discharges came sooner and sooner after onset. Also, at the front end, swallowing began to take precedence, resulting in fewer sessions devoted to aphasia. Other professionals began to take an interest in treating aphasia. The combined result was a decidedly negative impact on our aphasia services. So clinicians were forced to make decisions about what to treat in an increasingly narrow clinical window. Around this time, a group of like-minded clinicians and researchers began to talk about the state of aphasia services and brainstorm ways to address the issues. And these are just a few of these early thinkers that were communicating about these problems. We began to ask questions like, how can we deliver services that make a difference even within the current healthcare climate? What do we need to change so that people with aphasia can participate more successfully in their lives? This led to a small conference in the Napa Valley in 1997. So with a little wine and a lot of creativity, or maybe it was a lot of wine and a little creativity, I'm not quite sure, we began to address the concerns. While we were espousing